from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about head and neck cancer reconstructive surgery. Our guest today is Dr. Wesley McElwain, a head and neck surgeon specializing in reconstructive surgery at Sarasota Memorial's Brian D. Jellison Cancer Institute. Dr. McElwain, thank you so much for joining us.
Thank you so much for having me.
Can you start by just talking a little bit about your background and training, because your focus is pretty specialized?
Yeah, sure. I mean, for a little over 10 years now, my whole surgical career has been on surgery of the head and neck. And so I did my residency up in Seattle, Tacoma through the Army. I spent 4 years in the Army serving active duty as an otolaryngologist, head and neck surgeon, and I did some extra training focusing primarily on head and neck cancer and reconstruction of the head and neck, including facial plastic surgery.
So how does someone know specifically if they need surgery for head and neck cancer first? Because I know we're going to dig into reconstructive specifically after this.
Well, that's the big first part of the whole discussion is, why do you need surgery in the first place? And I mean, it's, we can have a whole nother podcast on that. It depends on where your tumor is, whether it's the skin of your face, or is it in your mouth, in your throat, in your salivary glands or your thyroid gland. So it really determines, where is the tumor, how big is it, are there any lymph nodes involved, is there any distant disease or metastasis? And then we really formulate that plan on, hey, do you need surgery based on what we call NCCN guidelines and the National Comprehensive Cancer Network guidelines. And so, a discussion with the patient, the radiation and medical oncologist, my partner, Dr. Vossler, we all come up and make a recommendation. And if surgery is indeed recommended as a first-line treatment, then we go down the route of, surgery and then reconstruction.
What are the goals of surgery for tumors of the head and neck?
To keep it simple, if surgery is decided, we need to remove the tumor in its entirety. And by that means we get clear margins. That means we remove the entire tumor and we get all clear margins, both, when we look at the pathology, essentially there's no cancer remaining at the edges of the resection.
Now, what life functions can be impacted by surgery of the head and neck? Because that's why you need reconstruction, right?
Yeah, and again, that varies as well. If we're talking about a large skin cancer removal, that's how you look, that's how you appear in public, and we try to reconstruct in a way that both, from a cosmetic standpoint, make you look as best we can, and to reestablish those aesthetic goals. But then you have tumors of the mouth, where you're talking about speech and swallowing and articulation and breathing. Those are all life functions that we take for granted on a day-to-day basis until something like a tumor of the head and neck can jeopardize all that.
So what are the goals of reconstruction after the removal of the tumor? Because tumor comes first, getting rid of the cancer is first, but reconstruction is so important.
Absolutely. And the foundation for reconstruction, especially of tumors of the mouth, throat, and neck, is to restore function. Okay, so again, so many functions: speech, talking, swallowing, all that we take for granted. And the goal of reconstruction is to restore function first. And then if we can restore form, like the way you appear and all that stuff later on, that's a secondary goal, but the first goal is to restore function.
So after a tumor is removed, what are some of the options available for reconstruction?
Sure. Now, if we're talking about, tumors of the skin, of the face, the nose, of the ear, we're really looking at trying to, move certain tissue nearby, like tissue, to restore that cosmetic appearance as best we can. Now, if we're talking about tumors inside the mouth or the throat, we're really talking about trying to restore function by separating the mouth and the throat from your other structures critically in your neck, like your blood vessels and your nerves. And so that can be in the form of tissue nearby called local flaps, regional flaps, so maybe tissue from maybe your shoulder, your chest we can bring up, or in the form of free flaps, where we bring tissue from other parts of your body, such as your arm, thigh, or your leg, to reconstruct larger defects.
So let's dig into that a little bit. What exactly is a free flap, and when would that be the best option?
A free flap in general is we're bringing tissue from other parts of the body and bringing it into the neck, and we bring the blood supply to it. So the artery that provides the blood into the tissue and the vein that drains the tissue, we bring that into the head and neck and to restore that defect, and then we hook up those blood vessels into blood vessels in the neck to restore the blood flow. So essentially that's what a free flap is. Now, the different types of free flaps really depends on what we're trying to rebuild. Everyone's body habitus is a little different, but in general, if we're trying to replace a thin area of skin, we borrow the thin skin from the arm If we need to replace a little bit more bulk, we may borrow some skin and muscle from the thigh. Or if we're reconstructing like your jaw bones, we may need to actually borrow some bone from other parts of the body.
So, how do you reconstruct a jaw? Because bone is obviously a little more complicated, and that's such a complex structure. So, how do you reconstruct a jaw after a tumor there?
And that's one of my procedures I'm very passionate about, because we're trying to restore function of these patients, and sometimes we have to, if they're missing teeth or whatever, we're trying to restore their ability to hopefully, eat, chew, swallow. So restoring the jaw, whether it's the lower jaw called the mandible or upper jaw called the maxilla, we use actually virtual surgical planning. So we use their specific anatomy of their face, their specific anatomy, usually of their leg bone called the fibula, and we make custom cutting guides and plates and screws to fit their original defect the best we can. And if possible, if we can try to already maybe put in some dental implants at that time, we can then start the stages of potentially dental rehabilitation much earlier.
And do those patients who have that jaw rebuilding require specific follow-up care or support after they've had such an intense surgery?
Well, one of my attendings in the past had taught me, and teeth is a goal but not a promise, and it's a journey to try to restore someone's teeth in different ways, but there's a whole team behind that. There's us as a head, neck, and reconstructive surgeons. There's the oral surgeons who place the implants, and then there's the prosthodontists and the other dental health professionals who help restore that. And that's a journey process for sure. But the very first part of that journey is to set all that up for success, remove the tumor, replace the jaw with the leg bone, if possible, with implants right away, so we can set that up for success later.
And do they require a specific rehab as well after surgery?
So all our patients need rehab, especially with speech and swallow. We have excellent speech language pathologists who are focused on head and neck to maintain their swallowing in a safe way. And so that's just one of the components of rehabilitation. These patients who need the larger surgeries, they may have to be in the hospital for anywhere from 4 to 10 days or so. And then afterwards, they're our patient for life. We watch them forever. We watch to make sure the tumor doesn't come back, and we also help them as their journey to recovery. If they need any adjuvant therapy, such as radiation or chemo, we help them through the effects of that. And there's always additional options later on that we can help them with, as they continue to heal.
You mentioned skin cancer before, and I think we want to dig into that a lot, because in Florida we see quite a lot of skin cancer. So do you reconstruct defects after skin cancer removal, and what kind of does that look like?
Well, that really depends. I mean, I think it depends on where the skin cancer is. I mean, a cheek skin cancer is a little bit easier to reconstruct because we have a little more tissue nearby. Mm-hmm. But things that really define our face, such as the nose, is nasal reconstruction after skin cancer is it can be quite challenging. There's different levels of treatment. Sometimes it takes a couple of surgeries, but usually the goal with skin cancer reconstruction of the nose or the ear is really the 10 to 12 month result. But smaller defects, you can really get a good result in 4 to 6 weeks.
And does that often require flaps, kind of like you said, or taking tissue from elsewhere in the body? Or
sometimes we need to borrow like maybe cartilage to support the nose to give us the support essentially. And that can sometimes be borrowed from someone's rib or maybe behind their ear. But in general, we don't really need to talk about big free flaps unless like there's a larger cancer of the scalp that we may need to reconstruct, and that's a whole different discussion about scalp reconstruction. But in general, down here in Southwest Florida, you just have to be vigilant about sunscreen, and we're very supported by our dermatologists in the area and also our Mohs surgeons, who Mohs surgeons are designed to remove the tumor by clearing all the margins, and then by taking as minimal tissue as possible, and then they usually send it to me for any reconstruction from a facial plastic standpoint.
Can you talk about the benefits to patients at a center like the Brian D. Jellison Cancer Institute, where everything's under this proverbial one roof, if you will, and you have that multidisciplinary team all working together, often in the same OR?
Absolutely. I mean, I'm very blessed to have joined a great group, and with my partner, Dr. Peter Vossler, who does similar head and neck cancer and reconstruction as I do. We work as a team, and we have tumor board every week. Every Thursday, a tumor board is made up of us surgeons, the radiation oncologist, the medical oncologist, the pathologist, and the radiologist. and the support team, such as our speech and language pathologist, our nurse case manager. We all work together. We review the cases, we review the data, we review the NCCN guidelines to make recommendations on treatments. And so having that all here at the Brian D. Jellison Cancer Institute is helpful. And with the new tower being built as well, it's going to be even better to have some of those partners even closer by. And then when we get to the surgery, we got a great surgery team. We're able to reduce the time of anesthesia quite significantly. And we know that if you can reduce the time under anesthesia with these bigger cases by having good partners, the outcomes are much better, the recovery is much better, the swelling's less, and the complications are much less.
And you mentioned to me when we spoke before that it's important to have the ability, when possible, to even do the reconstruction at the same time when possible, because then it's only one procedure, or it reduces the number of procedures if multiple procedures are required. Does that mean a lot to patients, and is that helpful?
Absolutely. I mean, again, achieving that first objective by getting the clear margins, I mean, we achieve that intraoperatively, and then we reconstruct at the same time. And usually, again, one person is, one surgeon's working on the, removing the tumor. The other person is at the same time working on the reconstruction. It's all working in a very smooth way in the operating room to, again, reduce that time under anesthesia as best as possible. And occasionally, we may need to do secondary procedures. And we sometimes stage these procedures to guarantee that clear margin. And if that's the case, that's okay. Then, our objective is to get the cancer out the first time around. If we need to do 1 or 2 surgeries to do the full rehabilitation to recover and to reconstruct you, then maybe that's sometimes best.
Is there anything else you want to add? I know this is such a broad topic, so we could talk about this for days if we needed to.
Well, I think what first drove me into the field of head and neck cancer is, it really defines who we are. We walk around, and it can be quite devastating for patients to have a tumor of the head and neck. And once they get that diagnosis, it's quite a journey. They come to see us, and cancer never comes at a convenient time, and nor is it a convenient location. And so I think that's what initially drew me into this field to begin with, is the resiliency I've seen over the years of patients. They see this train coming at them with what's going on, and then they're able to get through on the other side. And that's what's been very rewarding to me to see over the years, and why I love doing this so much. And I think being here at Sarasota Memorial, I just know we have a great support team to help them out throughout their journey, and they become patients of mine for life. So we always follow them up for life, and sometimes years down the road they want something here or there to help them out. That's things we were able to do for them. So that's why. That's, if anything I can add, that's what I would say.
All right, Dr. McElwain, thank you so much for joining us today.
All right, thank you.
As always, we encourage everyone in our community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.